Well, welcome. It's 8:01, starting time for grand rounds. And once again, I'd like to thank everyone for taking an hour out of your day to have some learning for yourself and take care of yourself in that way. So enjoy the 60-degree day on Sunday, our first super warm spring day. And then just two announcements. With COVID-19, please be sure you're checking your emails and reading them. There are almost daily updates in this very fluid situation from either the Department of Medicine or the School of Medicine and Public Health. And suffice it to say, UW Health has been incredibly organized in our response. But that's where you can find up-to-date information. And on UConnect, there is a page for COVID-19 with up-to-date information. And I just want to say this is my last grand rounds, and I've really loved announcing everything for this past year and a half. And Dr. Lynn Schnapp is here, and you will be seeing her hopefully in the near future. I'm not sure next week whether she's going to be moving or whether she'll be at grand rounds. So with that, I am very honored today to present our grand rounds speaker, Dr. Lisa Jones, MD, MP, MMCI, and I will tell you what that means in a second. Dr. Jones is going to be presenting Grand Rounds talk, which is Frozen Colon or Dyssynergia, Why Some Patients Can't Let It Go. Thank you for a super creative title. I love that. And I had to practice pronouncing that word a few times this morning when I got up. So a little bit about Dr. Jones. She did her medical school degree at Duke University in Durham, North Carolina, and during medical school received her Master's of Public Health from University of North Carolina at Chapel Hill. She then did her internship and residency at University of Pennsylvania in Philadelphia, Pennsylvania, and went back to Duke where she finished her fellowship in gastroenterology. And during her fellowship, she received MMCI, which is a Master's of Management and Clinical Informatics, also at Duke at the Fuqua School of Business. She has, during her career of training, done a lot of different interesting clinical things. She's been a hospitalist. She's been an emergency room doctor along the way as she's gone through her training. And she joined us on faculty very recently in 2018, and she joined us as an assistant professor on the CHS track. She, in that time between when she did her fellowship and joining us, has been on faculty at Marshfield Clinic in Wausau, Wisconsin, where she was a gastroenterologist specializing in pelvic floor and anorectal disorders. When I was looking through her honors and awards, I'm very happy to say that in 2019, just after she joined us, she was selected to be a member of the Centennial Scholar Program, which is a highly coveted program. And in 2012, she was acknowledged through the Division of Gastroenterology as one of the top 3 Grand Rounds presenters for 2012. So we're looking forward to a great Grand Rounds. So Dr. Jones, please come forward. Thanks. You're welcome.
Hello. Good morning. Thank you for joining me. Thank you, Dr. Trowbridge and the Department of Medicine for inviting me to speak today. You know, I was having a conversation upstairs with a nurse practitioner in anesthesiology, and we were talking about our paths to medicine. So how many of you are doing exactly what you thought you were going to be doing post-training? I'm doing exactly, well, Dr. Wald, of course. Yeah, so I am as far as you can get from what I thought I was going to be doing 7 years ago as possible. I thought I was going to be a GI inpatient doctor, GI hospitalist, which became popular back in 2013. And now I see patients specifically with pelvic floor and benign anorectal disorders. That means in a specialized clinic, I see patients with fecal incontinence mostly. Some patients who have difficulty evacuating, and we'll talk about that today, hemorrhoids and fissures, and I offer them some treatments. And that work really began at Marshfield Clinic, and I have to credit Marshfield Clinic for allowing me to build a clinic, because if I were to tell you how I got to Marshfield Clinic, it's a longer story, moving from North Carolina to Wausau. Wisconsin. But these patients were quite underserved, as they are typically in GI. I joined a 4-provider practice, 2 men, 2 nurse practitioners who were female, and so patients would say to me, oh my gosh, a female gastroenterologist, I'm so excited. Fairly common in our division, but like an anomaly then. And so I would be seeing particularly women with esophageal disorders, and they would say to me, hey, oh, by the way, can you take a look at this thing? And I would think, not it, not me. Or they'd describe fecal incontinence, and I'd go, despite how well I was trained, and I think the gastroenterology fellows in the room and even my colleagues would say we don't learn this stuff at all in fellowship. In fact, when we go over the digital rectal exam today, you will know more than I learned in GI fellowship, so good for you for being here. So I decided to dig in, right? Naturally curious, and found that there were lots of available treatments for these frustrating problems. And patients trusted me, and Marshall Clinic built a clinic around me. I learned how to read anorectal manometry, which I now do for our division, and offered some non-surgical treatments to patients. So for any of you who have felt a little bit lost along the way, to the trainees in the room specifically, I think my story is sort of a testament to how rewarding serving some underserved patients can be. So today we're talking really about constipation, and I'm so excited that you love the title because I spent some time working on it. And Eric Gomnitz, Eric, raise your hand. Shout out to Eric, who said to me, you've got to find a picture of Elsa. So I did. That's as strained as Elsa gets on Google Images. There you go. I thought you would love that. Okay, so I have no disclosures to report. And so this is really kind of a practical overview of the management of chronic constipation. So we'll start by getting you through the initial management of constipation, and most of you in this room are doing this really, really, really well. I'm going to convince you that keep doing what you're already doing in your clinics. We're going to talk about refractory constipation, and then specifically we're going to talk about dyssynergic defecation or functional defecation disorders. And these are the kinds of patients I see in my clinic. I hope to convince you to do a digital rectal exam if you can, because you can identify these patients quite easily. This is the outline for my talk today. And why should we care? Probably obvious to many of you. Constipation is quite common. So how many of you have never seen a patient with constipation? Right? Right, so they show up to your clinics. No matter if you're an oncologist or not, patients are saying, hey, I can't go to the bathroom. And interestingly, the prevalence rate of 16 to 33% is probably an underrepresentation of the burden of constipation. Most patients are going over the counter, right? So they're not seeing you, especially those with mild constipation, those who've had surgical interventions. They're just kind of grabbing things over the counter and self-treating. For the portion of patients that I see in my clinic, who are refractory patients, they report negative quality of life. They're obviously more likely to be dissatisfied with treatments. They complain of somatic symptoms. They're showing up more frequently to your office, bloating, nausea, dyspeptic symptoms. So it's an important subgroup to know. Before we kind of get into it, we have to kind of define constipation. And back in the 1990s, this group of investigators asked both patients and providers to define constipation. And the questions they asked really reflected like how limited our overall knowledge of constipation was, or at least the wide variety of symptoms that patients could have. They asked essentially 2 categories of questions, like frequency and stool consistency. So patients and providers were asked to define constipation on the basis of the following. Is constipation bowel movement less than every 2 days, less than every 3 days, 4 days, hard stools, don't know, and I think there was a writing category. And so patients were more likely to define constipation as a bowel movement less than every 2 days, providers less than every 3 days. But the Rome Foundation that helps us define constipation added a few definitions to constipation. Initially, it was just 4. These 4 symptoms suggested constipation: straining, hard stools, incomplete evacuation, and less than 2 bowel movements a week. At this point in time, it probably underrepresented the patients with significant anorectal symptoms, and so we now recognize that those patients are included in the constipation pool. So these are the questions I ask of patients, especially patients who present with bloating. Man, I think I go to the bathroom. I go every day. I'm not constipated at all. So in order to tease that out, we should be asking the following. Do you strain? Do you have hard stools? Do you feel incompletely evacuated? Are you having less than 3 defecations a week? Do you feel like there's a sense of blockage? Do you use manual maneuvers to go to the bathroom? So some patients splint on the vagina or expel stools using their fingers. And they have to have about 2 of these out of the 6 to meet criteria for functional constipation. In the absence of loose stools, and those patients should not meet criteria for IBS. So we're closer to bridging the gap. This particular study asked patients who reported having constipation about sort of Rome criteria, so they're presented a survey, and most patients met criteria for either functional constipation or IBS with constipation, those who were described as having constipation. And in this group, most of these patients weren't using laxatives. Their quality of life was pretty good, so we're closer now to bridging the gap. We understand these patients pretty well. Just a word about IBS with constipation. So the Rome Foundation defines functional constipation as separately from IBS with constipation. IBS with constipation is really pain-predominant symptoms. I'll tell you that it's really hard for us to distinguish this in clinic, as you probably know. Most of you are sort of nodding your head. What's discomfort, what's pain? And we know that many patients with functional constipation, so that list of 6 that I presented, also meet criteria for IBS and vice versa. So we might see an evolution in these definitions over time. That is, a description of constipation as either being painful or painless. That's where I think we're headed. So you're seeing a patient in clinic and you start with a thorough medical history, physical exam, and DRE, yes, the digital rectal exam. And we're extracting really the patients with secondary causes of constipation. So this is not a talk about opioid-induced constipation, spinal cord injury, those kinds of things. You're asking questions to determine whether or not alarm features are present in these patients, because those patients go to colonoscopy, right? And I'll give you some evidence that that most patients with constipation actually don't require a colonoscopy. In 2002, a retrospective analysis of about 17,000 colonoscopies extracted about 500 or so, and constipation was the indication for the procedure. The adenoma detection rate was 14%, lower than we typically see with asymptomatic or even average risk patients. And in the patients who had cancer, also presented with weight loss, overt bleeding, and anemia. And that makes sense to many of you, I'm sure, in the room. A 2012 study that repeated this of about 700 patients, and constipation was the sole indication for the procedure, no cancers. And the adenoma detection rate was about 2.9%, probably owing to the fact that this was a younger population of folks. And so we're more convinced that a colonoscopy is not necessary unless patients have these particular symptoms. Weight loss, iron deficiency anemia, rectal bleeding. They're without prior colorectal cancer screening. But I'll tell you, and I think most of my colleagues would agree anecdotally, that there's probably some reassurance value to a negative colonoscopy. And there's been one trial looking at this. So there were patients who had constipation, and they compared health-related anxiety scores before colonoscopy to after. And it turns out anxiety went down, and the only explanation per the investigators is that colonoscopy was completed during that time. And that makes sense to most of you in the room. Those patients with blockage feel like something's there, something is stuck. Those are patients I easily do a colonoscopy in. So in terms of where we start with management, again, most of you know this stuff and you're doing it. I'm excited to tell you, give you feedback. So we're starting fiber in most of these patients, especially patients with mild constipation. They respond really well to specifically soluble fibers. And fiber draws fluid into the colonic lumen. Bulking of stools happen as a result of the water, but also the byproducts of fermentation in the colon. And we get acceleration of gut transit. There's been multiple randomized control trials and systematic reviews with good response rate, and mostly defined as stool frequency and ease of defecation. Per our guidelines, the goal is about 25 to 30 grams of fiber a day, which you can obviously get in supplemental form. So most patients aren't meeting these goals. I add fiber supplement. Psyllium's been most well studied, but sure, methylcellulose and wheat dextran as well. Start slowly is the clinical pearl that I will offer, right? because efficacy is significantly delayed. So it's over a period of sometimes 4 to 8 weeks that I get folks up to 10 grams of supplemental fiber a day. So what about like the good lifestyle things that we think we should all be doing? Sad to say there's little in the way of evidence, but I'll encourage you to keep saying to patients, you should drink water and walk. There is really no data on water, specifically in chronic constipation in the adult population. In terms of daily exercise, there was a 2017 study. It was a clinical trial of women who were morbidly obese. And so in the intervention arm, those patients who were morbidly obese and had constipation were encouraged to walk at 15% incline on a treadmill for about 40 minutes with 10 minutes of cool down and 10 minutes of warm up. And those patients reported improvement in constipation severity scores and quality of life. Probably makes sense to many of you, right? They moved more. So that's the one piece of data or one piece of evidence I can give you for exercise. There's not much else. In terms of prunes, patients often say to you, I'm sure, like, why can't I just consume prunes? And sure, prunes have fiber, but it takes about 12 prunes a day to equal about 6 grams of fiber. And the efficacy of prunes over psyllium was demonstrated in one trial, probably owing to the fact that there's also sorbitol and fructans, so those non-absorbable carbohydrates create an osmotic load as well in the colon. So sure, have at it with the prunes, but it takes a lot for us to see some efficacy. What about probiotics? Some limited data, and that's because of the heterogeneity amongst the clinical trials. There's probably most evidence for Bifidobacterium lactis, but that gains us about just 1 or so bowel movement a day. I tend to use probiotics in patients who also complain of bloating and abdominal discomfort. So not a bad idea. And the clinical pearl there is I tell patients, sure, purchase a bottle of probiotics. If it doesn't work within a month, toss it. You'll find that many patients are on chronic probiotics without much in the way of benefit. Hopefully I don't sort of like dash the dreams and hopes of people in the room, but there is no data for DOCUSATE sodium. The proposed mechanism of action is that it decreases surface tension on stool, and so you get more water in. And then getting more water in, it creates softer stools. In 1998, that theory was tested, DOCUSATE sodium twice a day versus psyllium, and psyllium won in objective and subjective measures, so increased stool weight, increased water content, and quality of life, stool frequency, and softness of the stools in comparison to DOCUSATE. And other trials have been really negative since the 1950s. It is not part of my arsenal unless patients come to clinic saying, look, it works really well for me, I continue it. But in most cases, I'm not initiating DOCUSATE sodium in my clinic. The osmotic laxatives that you know quite well, like polyethylene glycol, are amongst everything that we've discussed, has the best data. So PEG itself has strong water binding capacity. Something like 1 molecule of PEG can bind like 100 molecules of water. So it draws water into the colonic lumen, increases stool liquidity and ease of defecation. It's most well studied, 19 clinical trials, all randomized, and 2 systematic reviews thus far showing efficacy above placebo. We tend not to use hyperosmolar agents, but there's really still good data. There's probably no good data for it, but it works really well. So if patients have bloating or flatulence with PEG, I start magnesium supplementation at these doses mentioned below. Stimulant laxatives work fast, and so they're effective. I use them specifically as rescue therapy in patients who've not gone in 48 to 72 hours, specifically choosing bisacodyl, either in oral form or in suppository form. There's probably no long-term damage to using bisacodyl chronically, but it works so fast, and there's a high risk, about a 30% risk of abdominal cramping associated with stimulant laxatives, so I relegate the use to really rescue therapy. So when you send a patient to us in gastroenterology, at this point in time, most of you have recognized that the patients have not responded to PEG, they've not responded to fiber supplements, lifestyle changes, those kinds of things. And so these are the agents we're familiar with in gastroenterology. So I'll talk about the secretagogues and the PROKINETICS specifically. And I think something of note is that drug development has been accelerating since 2006. So this is sort of an exciting time to practice GI and to help find solutions for patients. So lubiprostone, also known as Amitiza, was approved in about 2006, and we waited several years for linaclotide, or Linzess. 2017, a second dose was FDA approved, and then came plecanatide, precalopride in the next slide, and tenapanor most recently approved in September of 2019. And so what secretagogues do is they increase luminal water content, and they activate specific channels to do so. And if we can put our pharmacology hats on for a second, linaclotide and plecanatide activate guanylate cyclase receptors. And so once they activate the receptor, there's an increase in intracellular cGMP, which then activates CFTR channels, chloride goes out, and water and sodium passively follows. So you get an increase of water secretion into the lumen. This is a mechanism of action for plecanatide, just a different molecule. The secretagogues probably used less often. This is sort of the grandfather of the group, lubiprostone, and tenapanor, the newest on the market, not yet commercially available, works similarly, activates channels, which then increase water secretion. Well, what about manipulating a different mechanism of action? So precalopride is a prokinetic. It selectively binds to 5-HT4 receptors, epithelium, and on motor neurons. And the downstream effect is that we get smooth muscle contraction and increase in intestinal fluid. When clinical trials have also tried to discern how effective precalopride was in terms of its prokinetic effect, they looked to answering the question, how many high amplitude contractions will patients have a day on precalopride? And so high amplitude propagating contractions are the kinds of contractions that move mass movements through the colon, occurring a few times a day, usually postprandially, usually after awakening. So we've got 6 or so a day. And one small trial of patients who were given just one dose of precalopride showed us that the number of high amplitude contractions increases in the presence of the drug after one dose to about 8 in comparison to PEG. Now, some limitations of the clinical trials on these novel agents. And the first is that there's no head-to-head trials. And so if you ask me, well, how do you pick when a patient comes to clinic? The payer decides. That's the answer, as many of you know. The responder rate is about 19 to 30%, and that's what I'm telling the patients is the gain, right? The endpoints were kind of variable, all kinds of different measures, mostly complete spontaneous bowel movements. And the complete spontaneous bowel movement was a bowel movement that occurred in the absence of a laxative, and one in which the patient felt completely evacuated. So in some trials, it was greater than 3 complete spontaneous bowel movements a day and an increase in complete spontaneous bowel movement over 1. In other trials, it was complete spontaneous bowel movement. In other trials, it was just spontaneous bowel movement. You can see how we have difficulty kind of comparing the drugs as the endpoints were variable. If we use the most stringent endpoints, greater than 3 and an increase in 1, precalopride probably is the most efficacious, but we don't have really good long-term data with precalopride, so you will see. And then it begs the question, how clinically relevant is this measure of like greater than 3 spontaneous bowel movement and greater than 1? Yet to be seen. I tell all patients that there's a risk of diarrhea, and not one drug has a lower risk of diarrhea than the other. There was a theory that the lowest dose of linaclotide probably meant less diarrhea than the highest dose, and only slightly, yeah? So most patients will experience some loose stools, but it's rare for a patient to discontinue the medication because of diarrhea. So our initial management plan is that fiber, that healthy behavior stuff, that laxatives, and maybe the secretagogues and the prokinetics when patients get to GI clinic. But what about a patient who doesn't respond? And so this is a patient that I will commonly see in my clinic, and when my colleagues send this kind of patient to me, the question is, are we missing pelvic floor dysfunction here? And so imagine that a 40-year-old woman has constipation. She meets Rome criteria for chronic constipation or functional constipation. She's tried everything. There's no bleeding. There's no secondary cause for her symptoms. She's had a colonoscopy and her labs are normal. And so what do we do next in a patient like this? I'm going to try to convince you that evaluating this kind of patient for dyssynergic defecation is the next step. But practically, this is what I do. I think about whether or not we've missed a structural disorder in this patient. And so, of course, a digital rectal exam and history kind of gets to the bottom of this, and it's not typical that I will find a structural disorder that has been missed. So this is a picture of a rectocele. So vagina, rectum. The rectum is bulging into the rectovaginal septum because it's weakened. And so those patients might find themselves splinting, so inserting their fingers into the vagina in order to expel stool. So we get that history. Perhaps we've missed an intussusception, that the rectum is moving down into the anal canal, or extra-anal intussusception, also known as prolapse. But in the absence of those symptoms, the next step for a patient with medically refractory constipation is to evaluate them for dyssynergic defecation. Briefly, I'll mention that there's other subtypes of constipation, not just dyssynergic defecation, but normal transit constipation and slow transit constipation as well. And normal transit constipation is really the most common subtype. So when patients say to me, why am I constipated? They're mostly in the normal transit subtype, and the answer is probably for a lot of reasons. Maybe an imbalance in microbiome, bile acid metabolism, water secretion, those kinds of things. Slow transit constipation, the least prevalent subtype, is a true colonic motility disorder. And these are patients who have prolonged gut transit time, and we diagnose slow transit constipation with a SITS marker test. That is, they ingest radiopaque markers. We see how long it takes for those radiopaque markers to transition through the colon. Though we don't quite understand the etiology of slow transit constipation, I'll tell you there's two pieces of evidence. So these interstitial cells of Cajal, which stimulate smooth muscle cells to contract, are markedly reduced in colectomy specimens from these patients. And those high amplitude contractions, the ones that I mentioned that move mass movements along, seem to be lower frequency and less, again, abundant in patients with slow transit constipation. So an important subtype, but less prevalent. Then dyssynergic defecation. And so if you've not heard that term dyssynergic defecation, I am sure that you've heard obstructed defecation, pelvic floor dysfunction, anismus, functional outlet constipation. It all means the same thing. There's an inability to coordinate muscles to successfully evacuate. And that includes abdominal muscles, rectoanal muscles, and pelvic floor muscles. And I'll give you three pieces of evidence that we start here, for why we start here. The first is that normal transit constipation, yes, represents a significant portion of patients who presented to a colorectal surgery division for colectomy, medically refractory constipation. So these patients were likely referred back to a gastroenterologist to work on improving medical management. But about 28% of the group represented folks with pelvic floor dysfunction. And interestingly, pelvic floor dysfunction, dyssynergic defecation often overlaps with that slow transit constipation. So in this particular study, it represented about 3% of patients, and some would say up to 50% of patients with pelvic floor dysfunction also have slow transit constipation. And the third piece of evidence is correcting that dyssynergic pattern of evacuation tends to correct the slow transit constipation. So that's why we start there in terms of our evaluation. To understand what is abnormal, let's understand what's normal. So this is the rectum at rest. The puborectalis muscle wraps around the rectum, and it keeps this anorectal angle in an acute configuration. It essentially provides like a mechanical barrier to incontinence. With straining, what we expect to see is that there's an increase in intra-abdominal pressure, that's then transmitted to the rectum. The puborectalis muscle should relax. This angle should become more obtuse, and this sphincter should open. And that's what we expect to see normally. A patient with dyssynergic defecation, here's another synonym of probably paradoxical puberectalis syndrome as it was known a couple decades ago, those patients have contraction instead of relaxation of the muscles, closing off essentially the pathway to evacuation, or they have a contraction of the external or an internal anal sphincters, or they have incomplete relaxation of those muscles in order to successfully evacuate. It's not quite clear to us why this happens. Perhaps it's maladaptive learning. So evacuation is under voluntary control. And so patients have learned over time perhaps to hold. Perhaps they are avoiding pain or trauma or their social situations in which they have just learned not to go to the bathroom. There are no specific symptoms that differentiate this subtype from the other two that I mentioned before, so they all present with straining and hard stools and incomplete evacuation. Perhaps there's some association with sexual trauma or physical abuse that's yet to be teased out. And most interestingly, a few months ago, published in our American Journal of Gastroenterology, is a potential third risk factor, opioids. It's a group of patients that presented for evaluation for dyssynergic defecation, and they divided them in retrospective analysis between opioid-induced constipation and non-opioid-induced constipation, demonstrating to some degree that those with opioid-induced constipation were more likely to have a dyssynergic pattern on testing. And that could be clinically relevant, depending on how prospective trials tease out, because patients with opioid-induced constipation are often fairly unsatisfied with constipation management. So perhaps we should be screening these folks earlier on for dyssynergic defecation. So I'm going to convince you that you can pick this up on exam. The sensitivity and specificity of a digital rectal exam for dyssynergic defecation is like 75 to 80%, which is really cool. And so this is sort of my three-prong approach to doing an exam, which I've swiped from Dr. Wald and Dr. Satish Rao, who has been doing this work for a very long time. So we start with an inspection. So I want to know what the tissues look like. I want to know if there's soiling. I want to know if the anus is patulous, especially in patients with fecal incontinence. I perform, or I elicit an annucutaneous reflex as the second portion of the exam. And so the assistant passes me a swab. I swipe in 4 directions around the anus, expecting to see reflexive contraction. And again, that's very important for patients with fecal incontinence. Tells me whether or not sacral reflexes are intact. And then most important part for patients with pelvic floor dyssynergia is a digital maneuver, so the insertion of the finger into the anal canal. And when I do that, my hand is on the abdomen. I ask patients to bear down. Now in the most, yes, of course, unnatural position. So we ask them to bear down, and I expect to see some tightening of the muscles, so an increase in intra-abdominal pressure if they're evacuating normally, as my finger kind of moves down and out. So the anal canal should open while they're applying pressure intra-abdominally. So the rectal exam can tell us, so it's a nice screening tool for dyssynergic defecation, but by Rome criteria, we need physiologic testing, and we offer that physiologic testing here. This is anorectal manometry. So how many of you have referred a patient for anorectal manometry? Yay. How many of you know what to tell patients about the test? Nobody does, yes. No, that's where I was when I started clinical practice. I'm sending you for a thing, they're gonna do the thing, I'm gonna get a thing, and I'm gonna tell you what's going on, but most of the time, you have no idea what the report says, right? Tell me what's going on. Okay, so this is what happens. Patients are provided an enema prior to the test. It's a 30 to 45 minute outpatient test. They're working one-on-one with a nurse during that time, and they're lying on the left lateral position with this catheter inserted into the anal canal. There's a variety of measurements that this catheter can obtain, and we'll go through the maneuvers that we do. There's a balloon at the end of it, so we can inflate the balloon during the testing period. So this is a schematic of the rectum and the anal canal. The balloon's here. There's a sensor in the rectum and a few sensors in the anal canal. So initially we have them sort of relax. For 3 minutes they're at rest. We then ask them to squeeze And we do two things. We ask them to squeeze to get amplitude of squeeze, and but we also ask them to squeeze and hold, so we get a sense of whether or not the muscles are fatigable or not. And specifically for patients with dyssynergic defecation or those suspected to have dyssynergic defecation, we ask them to bear down, and we also do some rectal sensory testing. Just a word about rectal sensory testing. This is when we're able to inflate the balloon, like here. We slowly inflate the balloon, and we ask the patient to tell us, when do you first feel something? When do you feel like you have an urge to go? And we write those numbers down. And when do you want this thing out of you? Like, that's your maximum tolerated volume. And so we compare that to healthy controls. Patients with dyssynergic defecation are often hyposensitive, maybe telling us a little bit about etiology, the fact that they've deferred the call to stool for a while because of hyposensitivity. So during the bear down maneuver, what we should expect to see in comparison to rest is what I've mentioned before, that there should be a rise in the intrarectal pressure because you're applying abdominal pressure, and that there should be sort of opening of the canal. This is what we see in patients with dyssynergic defecation. They are closing off the anal canal most often, and there's variable patterns as to what's going on intrarectally. We need a second test. So we remove that catheter and we insert a balloon, and patients hobble over to a commode. We time how long it takes them to expel the balloon. It's called a balloon expulsion test. And 60 seconds is our threshold. I'll tell you that other labs, it's 2 minutes. And our algorithm for dyssynergic defecation, if both tests are abnormal, there we go, we have the diagnosis. If one test is abnormal and the other is normal, we're talking balloon expulsion and anorectal manometry, then perhaps we perform a defecography as a third test. And if they're both normal, we consider other subtypes of constipation. So this is a defecography. This is the barium defecography. I'll point your attention to an MRI defecography. So this is what things should look like at rest, that acute anorectal angle. And this is a patient during bear down who's contracting instead of relaxing, right? So this arrow is at the top of the puborectalis muscle. They're closing off the canal. So this is a patient with dyssynergic defecation. If we've diagnosed a patient with dyssynergic defecation, they head to biofeedback therapy. If all tests are normal, we look for slow transit constipation by ordering a SITS marker test. And how many of you have sent a patient over for pelvic floor physical therapy? And how many of you, keep your hands up, honest answers. How many of you feel really good about setting expectations? I know exactly what to tell. Hey, right. You are where you should be. So you don't have to read through this. This is a DOT phrase that was authored by Courtney Wack, who is a pelvic floor physical therapist, and it just helps to set expectations. I insert this into the after visit summary, just so patients are aware that there typically is an internal exam. This is .LJ pelvic PT for anybody who wants to know. So they're sometimes not aware that there will be an internal exam. They think it's a conversation about maybe hip flexor muscles and a little bit of back massage. And when they find out, as Courtney says, your therapist will perform an exam of your pelvic muscles, usually done internally, vaginally or through the rectum. And she goes on to describe the kinds of things they'll do during the encounter. So it's a 3 sort of prong approach. The first is that they provide significant education. They're better than we are at extracting information about lifestyle, behaviors, toileting time, those kinds of things. They spend most of the encounter working on correcting the mechanics of evacuation in these patients. And then they get homework, right? Which is sort of the most important piece. I'll tell you that when patients say to me, I tried pelvic floor physical therapy, it just didn't work. There are lots more questions to ask. And mostly we get to the fact that home exercises weren't sustained. Biofeedback is based on the principle of operant conditioning, and that is that when a behavior is reinforced, there's learning. And so typically there are sensors either on the abdominal wall, in the rectum or around the rectum, and patients can see on a screen what's happening to their muscles. So with coaching, they're able to relax. With coaching, they're able to contract, so contract, keep it up, relax, sort of your own sort of personal trainer for the pelvic floor, right? And they're sent home with reps and sets and things to do. There is good efficacy or good outcomes with biofeedback physical therapy. And there's been several randomized controlled trials. I'll point your attention to 3. The first one compared biofeedback therapy to PEG. And the response rate, I think, is interesting to note. It was 22% in patients with dyssynergic defecation. So I tell patients when I detect dyssynergia on pelvic floor exam or my rectal exam that yes, medications can take us so far, but we'll probably end up in biofeedback physical therapy because the response rates to laxatives alone are low. A second study compared biofeedback to diazepam and placebo, and a third compared it to sham biofeedback, meaning that there was a catheter inserted into the rectum but no direct coaching provided by a biofeedback physical therapist. Systematic reviews haven't been as optimistic, and truth be told, these trials have been small. The patient-reported outcomes in all of the clinical trials have not yet been validated. And biofeedback has not yet been compared to some of the novel agents that I mentioned before on the market, right? So maybe the efficacy will have decreased over time in the context of more potent agents for constipation. It is, as you are probably well aware, kind of a rare resource. It's a physical therapist who also is pelvic floor trained, who also has access to biofeedback equipment. And so perhaps we can predict who's going to be successful. I'll tell you that we really can't. It's hard to summarize these 3 trials. Perhaps if I were to take aim at it, these are patients with more severe symptoms who seem to be successful in biofeedback. But it's quite rare to have a biofeedback failure. And if someone says to me, look, I've been to biofeedback therapy, I typically contact the biofeedback physical therapist. We review what had been done and potentially repeat biofeedback, typically here or at another academic center. So can we turn this guy into this guy by changing positions? Maybe, maybe. We often recommend the use of a squatty potty or a stool, and that is that the puborectalis muscle seems to be more relaxed in the squatting position in comparison to sitting, but not much data. In abstract form last year, this clinical trial was published, 20 folks. They met criteria for dyssynergic defecation by having 2 abnormal tests. They were placed on a squatty potty, and the time to evacuate was calculated, and about 7 of those patients passed the balloon faster than they did at baseline. What about administering home biofeedback? So maybe patients don't need to come to an office. Again, it's a rare resource. So 100 patients were randomized to home or office. And this is a device that doesn't really exist specifically for this indication. I just kind of swiped it off the internet. What they created was a device that they sort of jimmy together, that they say that they're now developing. And patients who had the device inserted into the anal canal, saw flashing on the screens, learned how to use the equipment, were just as successful in terms of their composite outcomes as patients who had office-based biofeedback. What if there's true failures? So patients who truly fail biofeedback therapy, and typically in those patients we repeat the anorectal manometry and the balloon expulsion test. I'll tell you that the advanced therapies or the more invasive therapies are inconclusive and inconsistent, that perhaps there's some benefit to Botox injections into the puborectalis muscle. I know a couple of colorectal surgeons offer that here. It is rare that a patient makes it to colectomy. Most of our colorectal surgeons want to see that the dyssynergic pattern is reversed. And most patients who end up with colectomy after sort of end-stage constipation are typically patients with slow transit constipation. So thus far, we've talked about functional constipation. It's a multi-system symptom disorder. It's not enough to ask patients about frequency of bowel movements. That the initial management that you guys are already doing works. That a digital rectal exam in patients who are refractory is really important. It can pick up the possibility of pelvic floor dyssynergia, but it requires confirmatory testing, which we offer here, and that biofeedback works for these patients. Now, where should we be headed? So I'm excited about drug development. Certainly it's accelerating, but is novel better, right? And so we need more trials that compare these novel agents to standard of care. Can we combine therapy? Can we use a secretagogue and a prokinetic for some patients with refractory constipation? Can we target therapy? Can we potentially use prucalopride alone in patients with slow transit constipation, sort of that kinetic effect that I mentioned? How about device development for home-based biofeedback? And so I found this. This is a device that's inserted into the vagina with an app, several programs. There's some gamification as well. And interestingly, it was crowdfunded, which is pretty cool, right? So I think we're going to see more of these devices on the market. And finally, can we get these patients through that algorithm faster, right? And so there's a question as to whether or not balloon expulsion test alone is an effective screening tool. So something you can do in your office, timing patients in terms of how long it takes them to expel the balloon. There's some evidence for that. And I'm particularly interested, however, in medical education, specifically improving trainee awareness and education around pelvic floor disorders so that these patients no longer remain underserved. So that's it for my talk today. We let it go. And I'll take some questions.
Fantastic. So as a dental internist, that was just so helpful. And questions from the audience?
Yes?
Yes.
Do colonic manometry tests for adults?
We don't.
Repeat the question.
Oh, thanks. Do we do colonic manometry tests? We do not offer colonic manometry tests here. They're offered at other academic centers. Colonic manometry test tells us about a little bit more about slow transit constipation, calculates the high amplitude contractions that we saw. So often, unfortunately, we don't offer it here. Catheter inserted by colonoscopy that's taped in, those kinds of things. Yes?
So you had listed on one of the slides that misoprostol was an alternative. Do you use that before?
Only under the direction of Dr. Arnie Wald.
So repeat the question.
Yeah, so misoprostol, prostaglandin, does it work for constipation? And Arnie, you could probably speak to that. He has more experience with it. I've used it in patients who I think are on the way, quite frankly, to colectomy. Really sort of super end stage patients and very minimal data. But Arnie, you have more experience with misoprostol than I do.
The short answer is it's yes, in very special circumstances.
Yep. Very good. Yes? Hi.
It occurs to me, since the bladder function is controlled by the same sacral plexus, many of these women may also have bladder dysfunction. I'm curious, when you do the biofeedback to improve their defecation, does their urinary incontinence also improve?
Sometimes.
So repeat the question.
Oh,
Or the statement.
yes. So does bladder function improve with correcting defecation? Many times it does. I'll tell you that many of my patients do come from urogynecology. So those are patients who have stress urinary incontinence, and our urogynecologists have discovered that part of their problem is they can't empty their bladder because their rectum is full. And so they'll be referred to us for evaluation. And so theoretically it should. I'm not sure that I've followed patients in terms of that particular endpoint, but yes, it does make sense mechanically that it does. Yes?
Do you have any reservations about general internists starting to prescribe something secretagogues specifically for patients who fail the sort of first-tiered approach to constipation in general medicine?
I don't.
So repeat the question.
Thank you for the coaching, by the way.
I know, yeah.
So any reservations? Do I personally have any reservations with internal medicine providers prescribing secretagogues for patients with constipation? And the answer is no. As with most drugs, as long as you understand the implications of the management and know when patients are becoming refractory, it's really important to kind of continue to ask them questions about efficacy. I tell patients to call me in 2 weeks. And so if we're starting linaclotide at 72 micrograms, I ask them to call me in 2 weeks. And if it's effective, let me know. But if it's ineffective, we'll double the dose. So like with anything else, time, education, understanding the literature is helpful. I don't know if any of my gastroenterology colleagues feel differently about that, but that's where I stand. Go, please, please. Yes?
So, very nice talk, Lisa. I'm curious if colectomy is the sort of the last resort. Are they able to tailor it to the individual based on, let's say, the colonic transit study, or what exactly are they doing when they're resorting to a colectomy?
Yeah, for patients with dyssynergic defecation, like true failures of biofeedback therapy, then an ileorectal anastomosis really doesn't make sense for these patients. So fairly often they're ending up with end ileostomy. For slow transit constipation, it's typically a total colectomy with ileorectal anastomosis. And that's a rare population of folks. I mean, we sent maybe 1 to 2 patients in the last 16 or 18 months to colectomy, both with slow transit constipation. Yes?
Follow up on that. With the peds population, why is a Malone or cecostomy usually tried before the versus adults?
I wish.
that question.
Yeah, so cecostomy or Maloney, so this idea that you create a stoma in the abdomen to allow for enemas to be inserted into essentially the colon, flushing out the colon, is more common amongst the pediatric population who's refractory to medical management than the adult population. And so I know very little about the pediatric literature, and I'm not sure how to answer that question. If you find the answer, let me know. I did have an adult patient ask me about it, and I really didn't have anywhere to send them outside, instead of sort of outside of the system. Yes?
So I see a male population that has had lifelong anal intercourse.
Yes.
Do we know physiologic changes that occur in this population?
Yeah, there's been, I think,
Repeat that.
so in a population of men who have anal intercourse, what do we know about, I guess, anorectal function? Would you say that that's correct? Yeah. So they are at higher risk for fecal incontinence. That's what we know on the basis of retrospective reviews. In terms of constipation or dyssynergic defecation, I'm not aware of any literature that suggests that they're at higher risk for dyssynergic defecation, but I think it's an interesting question that you ask. Yes?
Has insurance been a barrier, insurance coverage been a barrier for biofeedback at all? For
Yes,
referrals?
significant barrier.
So the question was, is insurance been a barrier for biofeedback, or I assume secretagogues and other things? Yeah. So
At this point, are you like, come on, lady?
no, I'm not. No, I'm not. I know it's a pattern. Yeah. But I know people. That
I'm right here. I just like, are they here? Are they not? Like, so what's insurance coverage for biofeedback like? And yes, secretagogues as well. Pretty terrible. So, gosh, you bring up a good point. I wanted to avoid this question. So here, with courts as the insurer, biofeedback is not typically covered. So our biofeedback physical therapists are usually trying to hide biofeedback into the therapy. If they use biofeedback for less than a certain number of minutes, then they can get by. So it's a significant barrier. It's about $90 per session. So some patients pay out of pocket for it. So yes, significant barrier. And for the secretagogues, as I mentioned before, the payer is going to tell you which secretagogue you're going to use. Most likely they cover Linzess. All of them are in the similar cost range, about $400 to $500 per month, right? So pretty hefty. And if you're going to escalate therapy, you're going to have to prove with significant evidence that they're refractory to your initial management.
I have one question, which is, which you don't have to repeat because I'm talking right into the thing. So, with so many patients having this be a very significant issue, do you have, as one provider, and maybe 2 or 3, do you have access in the clinic that you run to get patients in, or is that a significant issue even at this point?
I'm going to pack up and leave now. So I think generally access is an issue in gastroenterology, and I'll give you sort of the hopeful answer.
Question, please.
I hope that we can train the next generation of gastroenterologists to do this work. Many of us are seeing these patients with refractory constipation. It's only when they become refractory to secretagogues do my colleagues send patients out to either Dr. Wald mostly or myself. But yes, access does remain an issue. I think this is sort of my first sort of coming out, telling folks that I exist, because most of my patients actually come from our urogynecology and urology colleagues. I would say followed by our gastroenterology APPs, and then our my gastroenterology colleagues. So I'm available to see patients, and yes, access will be an issue. Our APPs and our the other providers in the room do a really nice job ordering anorectal manometry, and so that's a test that I interpret as part of my time.
Thank you very much. Any other questions? Wow, this is fantastic.